So, hello again. I'm Randy Kearns, and I'm your professor for the Disaster Management Program. For this particular lecture, I want to spend a little bit of time going over the circulatory system, gunshot wounds, and hemorrhage control. Key terms for this lecture include we'll talk a little bit about the anatomy, arteries, veins, venules, arterioles, capillaries, and then we'll talk about methods of controlling life-threatening bleeding with direct pressure, elevation, pressure points, and a tourniquet. We'll talk about self-care and buddy care, bandages and dressings, what's the difference between the two, and then defensive weapons and offensive weapons, what's the difference between the two. So I think we've already had the active shooter part of this of the presentation this semester, but I do want to spend a little bit of time going over gunshot wounds, ballistic differences, although I think I did cover that in active shooter, but again, just some of the basics of that. Stabbings, accidental injury, active shooter and medical care, and then specifically talking about managing life-threatening bleeding with direct pressure, elevation, pressure points, and a tourniquet. So the best way to think about how we deal with life-threatening bleeding is to also think about how blood flows through the body. Center of the chest, actually just to the left of the sternum, is your heart. It's got 4 chambers. It's a closed system, and every time it squeezes, it pumps blood out either to the rest of the body or actually to the lungs to pick up oxygenated blood. So when blood leaves the heart, it generally moves through really large arteries. Those really large arteries carry a great deal of the volume of blood within your body. If we damage or rupture one of those arteries, we're far more likely to have very serious life-threatening bleeding. Things that you would see that would tell you that something has injured an artery is it's more likely to be spurting, and it spurts in a rhythmic way based on the heartbeat of the patient. If you've never seen it before, it can be a bit unnerving. It can be a lot of blood in a very short period of time, and it is obviously life-threatening and can be very serious if we don't manage it quickly. Arterioles are the smaller arteries, less serious, and typically when we're talking about arterial bleeding or capillary bleeding, it's a lot easier to control that with direct pressure, elevation, and pressure points, and I'll talk about those approaches shortly. And the same thing with once blood reaches kind of the terminal points within the body, that's the capillary beds where oxygenated blood is used and provides nutrition to the body and energy to the body. It's also in the capillary space that blood is picked back up to return to the lungs to be oxygenated. And so it's going to return through venules, and then the larger veins, or the larger return of the body, is the veins. Veins, if we interrupt a vein and it's bleeding, it's more likely to have a more purple color, and it's more likely to ooze and be a constant bleed as opposed to that bright red spurting bleeding that we see with an arterial bleed. Just understand that with an arterial bleed, somebody can die in as little as 3 minutes. Again, it really depends on what artery was damaged and how substantial the damage was, but it's really incumbent upon us to act quickly. And that's, in a minute, I'll talk a little bit more about self-care and buddy care, but again, how do we provide care for ourselves? How do we provide care for somebody in the immediate area of where we are? The best way to think about places that we can slow down blood flow distally, meaning away from the heart, is to apply pressure over a pulse point. Well, a pulse is any place where an artery passes over a bone, and as we press that artery against the bone, we can feel the pulsation of the heart. And I would suggest that on yourself, you check your radial pulse. Radius is on the thumb side. This bone is the radius. There is an artery here just over the radius. It's called the radial artery. If I take my two fingers and I press into that space, I'll feel my radial pulse. If I want to feel my carotid pulse, so windpipe, move just to the side. This is the sternocleidomastoid muscle. Not necessary that you know that, but there's a muscle here. Windpipe, also known as the trachea, is here. In this space between the two is a good place to check the carotid artery. The brachial artery is here. Just pressing the brachial artery against the humerus. Again, the only bone in the upper arm. Femoral artery is in the groin. I'm putting pressure, again, compressing the femoral artery against the femur, the large bone in the upper leg of the body. The popliteal artery is behind the knee. Putting pressure on the popliteal artery and putting pressure against the head of the tibia, which is the large bone in the lower leg, the bone on the front of the lower leg. The large bone on the front of the lower leg provides structure for the body, that is the tibia. If I go down to the back of your what looks like your, sometimes we'll call it an ankle bone, but it's the distal portion or the lower end of the tibia, and there's a portion of it that is medial, meaning toward the center of the body, and a portion that's lateral. If I go behind the medial portion toward the center of the body and put my fingers behind that lump in your ankle, so to speak, there's an artery there. It's called a posterior tibial artery. And then there's also one on top of the foot. And we refer to that as sometimes the pedal pulse, but also the dorsalis pedis pulse. The big point is any place that an artery is in an artery lies over top of a bone and it's close to the surface of the skin. If there's bleeding between the heart and if there's bleeding beyond that pulse point away from the heart, then we can put pressure on that pulse point and slow down the bleeding beyond or distal to where that pulse point is. It can, it's called a pressure point. And if we apply pressure to a pressure point, it can slow down blood flow beyond that area. So bleeding injury and bleeding scenarios with gunshot wounds, it really depends on the nature of the wound. Obviously, it depends on where the wound is located. With stabbings, the same way. Accidental injury, the main thing that I would point out with an accidental injury is it's with purposeful injury, we're far more likely to know what somebody was shooting at or what someone was intending to injure. With accidental injury, it can be anywhere. The other point about an accidental injury is you're far less likely to be concerned about the person who perpetrated the injury to continue to be a threat on the scene. Offensive weapons versus defensive weapons. Again, I think this was covered in active shooter, but let me just mention a couple of things. We typically refer to a sidearm as a defensive weapon. I've got a couple of examples here. A SIG 225 and a Walther PPK are a couple of examples. A Glock 17 is a common police officer type weapon. And a Glock 17, as an example, means there are 17 rounds of ammunition in the clip, which is a little bit much for most handheld type weapons or sidearms, also known as defensive weapons. The other point about a sidearm or a defensive weapon or a pistol is the velocity of the projectile coming out of that gun is going to be slower and more likely to be repelled if someone's wearing body armor or ballistic armor. A stored weapon or an offensive weapon, and again, we get the stored weapon and sidearm terminology from our friends in the military. They typically store their large rifle automatic weapons. For a military person, it may be an M16 or some variety of that, but our civilian version of that, and it can be any number of things. We refer to a lot of things as an AR style weapon, but an AR-15 is that common example. Clip is about 30 rounds. Just understand the velocity of the projectile is much faster and can penetrate most standard body armor, and therefore we have a great deal of concern about someone using a weapon that's an AR style weapon, even more so than someone using a handgun. Again, offensive weapons versus defensive weapons. The defensive weapons are more likely to be sidearms and more likely to be a handgun. Today, people are more likely to use weapons that have a clip as opposed to some of the older weapons were far more likely to be a revolver style, which typically has 6 bullets. But anyway, the whole point to this is just understand that if someone's using an offensive style weapon, and without getting into the nuances of specifically what type of rifle it is, just understand an AR style weapon is far more dangerous and can produce far more catastrophic injury and is a lot more deadly for even people wearing what would otherwise be ballistic body armor. Ballistic body armor will withstand defensive weapons, but typically will not withstand a shot fired by an offensive style weapon. Again, this kind of gives you an idea of the difference between handguns and rifles, and then what the type of projectile looks like. And then types of bullets for small arms. Is it something referred to as a full metal jacket? If it's a full metal jacket, it's more likely to produce a through and through type injury, meaning the entry point probably looks small, the exit point probably looks small. The amount of bleeding that we see at the surface may be minimal, but it may have caused a lot of damage underneath that's difficult for us to see. And I'll talk a little bit more about that in a minute. A hollow point or a jacketed hollow point can be far more catastrophic. The intent with a jacketed hollow point type ballistic is upon impact, it spreads out, it creates a much larger injury, particularly on exit and all of the tissue in between. So once it has initial impact, anything beyond that, again, it'll spread out, it'll cause a lot of damage. The idea with a jacketed hollow point is it stops someone in their tracks. It's intended to cause a lot of harm. It's certainly intended to stop someone from doing whatever they were doing. And it is a common type of ballistic used in law enforcement, but also used in a number of other sidearms. The bullet wound at the top right is a great example of an exit wound with a hollow point. The bullet wound in the lower right is a great example of an exit wound from a full metal jacket. Again, full metal jacket's going to give you a kind of a clean entry, clean exit without a lot of destruction of tissue. A hollow point type projectile is going to give you a lot of destruction of tissue on the exit, not necessarily on the entry, because it obviously it has to have impact first before it spreads out. But on exit, it'll cause a lot of damage. And I don't mean to provide such graphic images, but you do need to see what type of injuries you could see with someone having some type of a gunshot wound. Stabbing or accidental injury, you know, so the patient in the upper right corner, I've actually seen a couple of those patients that, again, the intent when someone stabs someone just below the sternum or the little tip below the sternum, it's a xiphoid process. When someone is stabbed there, they're typically going for the heart. They're typically trying to kill someone. And honestly, one of the most important things we can do if we get there and someone's still alive, again, from your standpoint, you want to protect yourself and you certainly want to protect your patient. But you know, if that's not what you're trained to do, you need to, first of all, think about protecting yourself. But one of the most important things you can do in terms of helping take care of the patient is to not remove the weapon. I've actually seen, as the heart was beating, you could see the knife move at the same time the heart is beating, which tells you that the blade is somewhere lodged into the wall of the heart. We have to be very careful with those patients. We have to move them very quickly, but also very safely. They need to go to the operating room immediately. That's one of those types of things where, as long as we don't move the blade and there's not a lot of bleeding around the blade, I have seen a patient survive this type of injury before. But many patients who wind up with a stab wound to the heart wind up dying. Most stab wounds are defensive type wounds involving the hand or the arm. Most of the patients I've had that had those types of wounds, again, were defensive type wounds and more likely to be the hands or arms. If someone gets close contact to the chest or abdomen, far more likely to be very dangerous and potentially fatal. Again, active shooter and medical care, just understand that most of the information we know about active shooter type scenarios, it's really much more of a recent phenomena. We've had active shooter type scenarios for 75 years. We just haven't had them to the degree and frequency of what we see them today. And why that's occurring, I won't pretend to offer answers or solutions for that. Just understand that when you hear somebody talk about an AR-15, AR does not mean assault rifle. We're far more likely to describe it as an AR style weapon, but AR actually stands for Armalite rifle, which was a particular weapon that was created in 1957. Again, it's more of a civilian version of an M16. If you've ever looked at an M16, they look very similar to each other. I've got a handle on top, clip that's typically a 30-shot clip. An M16 has a switch between a burst, a fully automatic, and a single shot, so that you can, each time you pull the trigger, it fires one bullet. A burst is typically a 3-shot burst. When you pull the trigger, it'll fire a burst of 3 shots. And the point is, you really lose your accuracy if you try to pull the trigger and just hold the trigger. You lose muzzle control, and so the front of the weapon starts moving around a lot, and it's very difficult to control the pattern of where you're trying to fire your weapon. Anyway, anytime you're dealing with an active shooter, we want to, first of all, protect ourselves, protect those around us, secure the area, um, and then what type of access do you have to medical care? Is there an aid kit nearby? What other things can you do to improvise? Um, Understand when law enforcement arrives, particularly Columbine really changed the way most, the training for most law enforcement agencies in terms of how they deal with an active shooter type scenario. Most active shooter scenarios are over within 15 minutes from the time the active shooter arrives on scene until the time the last shot is fired, and and generally it's a he, is leaving the scene is about 15 minutes, and typically less than that. So just understand that what's best for the casualty may not be what's best for the mission. Um, Typically, law enforcement is going to be focused on finding, actively seeking out and engaging the shooter and stopping the shooter from doing what he is doing. And what that also means is if they approach you, talking about a law enforcement officer, one of the things I would commonly say is hands, show me your hands. Be sure and show them your hands. Don't move quickly. Don't make sudden movements. Don't act like you're trying to conceal anything. Follow all of their instructions clearly. But understand they're not there to really rescue you or certainly to provide medical care. They're there to engage the shooter. Now they may channel you out behind them and back out with you, depending on how many people are in the attack team, who's who's in what position of the group. But just understand their first role is not to provide medical care to you. Their first role is to seek out, find the shooter, the perpetrator, and disarm or stop further violence from continuing. Again, before Columbine, law enforcement was treating this as more of a hostage type situation. They came to realize that active shooter type scenarios typically aren't hostage scenarios. Um, and so, in terms of rescuing hostages, again, rapid evacuation, brief time for life-saving intervention, and that's why I get back to buddy care and self-care. The best care you're going to receive early on is probably the care you provide yourself, and the best care you can provide for somebody else, somebody that may be injured with you. I used to remind paramedic teams responding to these types of scenarios. Sometimes you get a call of an unknown rescue and you arrive, and the next thing you know, it's an active shooter type situation. I would, if a shooter shows up, you need to leave. If you can take the patient with you, take the patient with you, but you've got to protect yourself. Get out of there. And that's what I would tell you. Try and, if you've got a friend there, try and take them with you. But again, the only thing worse than them being hurt is you being killed while you're trying to move them because they slowed you down. And those are really tough decisions to make. I've never had to make a decision like that. I have been in a scenario of more than once where somebody had a weapon who was trying to harm other people, but usually there were other people there at the same time who were armed, not me, but who were armed and able to kind of secure the scene and secure the situation. And that's really what's important, is the people who are trained to do that are the ones doing that. Casualty movement, again, locate cover, don't understand construction materials. If you're in a room that most walls are made out of sheetrock will not stop a projectile fired from any type of weapon. So just know what type of construction you're around, know what is sturdy, what is not. Hiding under a desk or behind a desk is better cover than just hiding behind a wall that is typically sheetrock. moving the casualty to cover, the risk to the rescuer. Again, every scenario is a bit different. Um, um, if um, if there's a weapon to be recovered, most training will tell you to try and recover that weapon. The only concern I would have is I wouldn't want you to handle a weapon that you've not been trained to handle. But at the same time, if there's a way you can cover it up so that someone can't get to it, that is typically helpful. Um, I, when I've taught this course before and we were seated, we did practice moving patients. Obviously, that's not something available to us in an online class, but there is some information that we'll cover later on about moving patients. Just understand the good news and the bad news about bleeding, and this is kind of a dark humor, is all bleeding eventually stops. My encouragement is be sure you're the one causing it to stop. Direct pressure is the most common way we attempt to stop life-threatening bleeding. Elevation can help, particularly if it's an injury to the arm. If we can apply direct pressure and elevate that injury, and when I say elevate, elevate the injury above the level of the heart. It's harder for the heart to push blood up than gravity always wins. So again, think about elevating the injury above the level of the heart. We're going to typically place the patient in a lying position. We also call that a supine position, and elevate the extremity if there's an injury to the extremity. A pressure point is what I mentioned earlier, and that's finding a pulse, and wherever the pulse point is, applying. So let's say we have direct pressure, we have elevation, and we can apply pressure to a pressure point. That allows us to again, stop or significantly slow down life-threatening bleeding. Um, Sometimes we can't stop life-threatening bleeding, particularly if it's an arterial bleed. Sometimes if it's a really serious venous bleed, we'll use a tourniquet, but this is called a windlass, and it refers to how we tighten down the tourniquet. But a tourniquet may be the only way to stop bleeding. Um, do you have access to one? You know, this is kind of an environment that I've worked in before. I have one in my office, I have one in my car, I have several at my house. Tourniquets are rarely needed, but when they are needed, they're essential, and they play such an important role in stopping life-threatening bleeding. This is an example of um, a, um, a firefight involving soldiers in the U.S. Army. The medic for this particular unit was KIA, that means killed in action. Others were injured. This particular soldier was treated by fellow soldiers, and they created this makeshift tourniquet. Um, the problem is the tourniquet did not stop the bleeding. The soldier bled out and died of a leg wound. Um, Really a tragic situation, because just understand, most any wound to any extremity in isolation, that's a survivable injury. We may not be able to salvage the limb, but any injury to any limb is typically a salvageable injury, and that's certainly a life-saving type opportunity as long as we do it correctly. Um, um, I used to work in a school of medicine where 18 Delta instructors, which are the 18 Deltas are the medics for the Ranger Corps, the instructors for them would spend some time with us, and spent a lot of time um, both learning from things that we did in the trauma center and the burn center, and then also taught us some of their experiences from um, uh, deployments, and some of the things that they saw, and this was certainly one of those examples. Again, things to do with the tourniquet: tighten it until the bleeding is controlled. Be sure and place it proximal to the bleeding site, means about 3 inches above where the injury occurs, and the tourniquet needs to be on an extremity between the location of the heart and where the injury is. So if the injury is here on my arm, let me see, sorry, here on my arm, then I want to be sure the tourniquet is 3 inches above that point, and it may wind up being above the joint. But the whole point is I want to be sure and put a tourniquet in place. And we do want to check for a pulse below that site, but we're not so concerned about did I maintain a pulse or did I lose a pulse. We've got to stop the life-threatening bleeding, and we've got to tighten down the tourniquet until we stop the life-threatening bleeding. Again, we would like to salvage the limb, and in many cases we can salvage the limb, but we certainly want to save the patient, and we don't want to try and compromise the patient's life with the aim of, well, we want to try and salvage the limb. Our first goal is to save the patient's life. In some cases, we may need to apply a second tourniquet. If we do, 3 inches above the first one, and again, closer to the heart is typically the best place to do that. It should go without saying, but don't use a tourniquet just for minimal bleeding. Don't put it too close to the injury. Don't wait too long to use one. If the patient tells you it hurts, it probably means you're doing it right. Don't take a tourniquet off because it hurts, because it probably will hurt. If the patient goes into shock, again, be sure not to take it off. Don't loosen it. And certainly don't apply one on the neck. There are certain types of compression devices made for bleeding in the groin and bleeding in the armpit. We're not going to cover that in this, and that's not a tourniquet, but there's a type of device that can be used for things that are closer to the shoulder or closer to the groin. Again, not a tourniquet and not something we're going to cover in this course. Don't put a tourniquet directly over a holster or a cargo pocket. If there are bulky items in the cargo pocket, be sure and remove them. Again, this is a combat application tourniquet, otherwise known as a CAT or a windlass CAT. One-handed application of the tourniquet. Be sure you can, if you've never seen one of these, actually there's some fairly inexpensive ones out there on some of the common sites. They work and they're probably okay, but sometimes they break and sometimes they don't work as well. Be sure that you know how to make an improvised one. A belt is a great way to make an improvised one. A shoestring is not a great way to make an improvised one. If we go back to the picture I showed you earlier of the soldier who bled out, they were using a parachute cord. And parachute cord works for a lot of things, and it's a really common solution for a lot of problems. It's not a common solution for a tourniquet. It needs to be something wide. A belt is a good wide item that does work reasonably well for a tourniquet. Again, this is just one-handed application of the tourniquet. This is the windlass CAT, which is, again, one of the most commonly sold tourniquets. Now, these can be a little bit more expensive. They are the brand version, and they are the ideal version. They certainly don't break, and they certainly work well. Yeah, you twist it until it's tight, and then you use Velcro to help secure it in place. There's actually a little clip. If you ever get a chance to use one of these, you'll twist it until it's tight, and then as you can see on this image, there's actually 2 plastic clips, and you can tuck the windlass up under one of the plastic clips and then fold over the Velcro restraint, and it'll hold it in place. The only thing I would tell you about casualty movement and then casualty movement, these are some from these images or some from some of our military friends that we've worked with. But a one-person drag or a two-person drag or a three-person carry, all of these are intended to help move somebody quickly out of a difficult situation. Um, Single-person movement, two-person drag, um, a carry, referred to as the SEAL team carry. I assure you, our Army friends don't call it that, but anyway, a three-person or a two-person carry. Um, then a Hall's carry. Again, this is more of a someone over the shoulder, um, depending on how well you can handle the size of somebody else would depend on how well you can do this. And this kind of takes us to the end. The main point I would make about the presentation today is this. Again, just understand that different types of weapons produce substantially different types of injuries. I had a patient one time that again, you have a lot of defensive wounds, was holding his hand up and was shot with a .22 caliber revolver, and a really low velocity projectile. It actually followed his arm over to his chest. Um, he did not have a serious injury, but nevertheless he had a gunshot wound. But it did remind you how the bullet could move and travel and follow the contour of the body, because it was traveling at enough velocity that it did that, but didn't have enough velocity to kind of maintain its trajectory. Other types of weapons and other types of injuries can really produce some catastrophic stuff. Um, Sometimes people will tell you, I don't like the sight of blood. The reality is no one likes the sight of blood. That's why we have those bandages to cover, and the bandage that goes directly on the wound should be sterile, at least very clean. That's what we call a dressing. The thing that we wrap around the dressing to hold it in place is a bandage. Um, and again, the aim is to stop the life-threatening bleeding, do the things we can to save somebody's life. It really starts with self-care. Can we take care of ourselves? Buddy care. Can we take care of our friend? In preservation of life, how well can we preserve both the life of others and certainly our own? I hope that helps. And anyway, that's it for today.